name is Dr. Ina Park. I'm the medical director of the California Prevention Training Center and a professor at the University of California, San Francisco in the School of Medicine. And the California Prevention Training Center is bringing you this expert hour webinar called Herpes Simplex Virus Infections. It's complicated, by our fantastic expert speakers, Terry Warren and Christine Johnston, who I'm going to introduce in more depth in just a moment. But I have to do some, compulsory CME slides for you, so you know what our regulations are around CME, and to tell you a little bit about our center. So the California Prevention Training Center is a multidisciplinary capacity building and training center. We are funded by CDC, and we're part of a national network of actually 8 different training centers. So we do both in-person and virtual events like this one, as well as provide technical assistance and provide also one-on-one consultation services for folks with complex STI issues a bit more later. So again, here's our 8 centers. Our region covers, 4 states here in the West, as well as Hawaii. And Christine happens to be the medical director of the University of Washington Center, which is up here in the upper left corner. And I did mention about complex clinical case management. That could include complex herpes cases as well. We have a funded online clinical consultation service, the stdccn.org. Consults are answered within 1 to 5 business days, depending on your preference. So I do welcome you to send us, any consults that you have on herpes or any other topic. So I need to show you some financial disclosures here as well. This is standard CME language from our CME provider, which is the University of Nevada, Reno School of Medicine. And it just states that our speakers do not have any disclosures at this time, and that the CME disclosure statement as well talks about the number of credits that this webinar is going to receive, which is 1.25. And please note that the registration for the webinar is closed. If you are viewing the webinar at this time because someone forwarded you a link or something, you're not going to be getting a notification with the post-course survey because you needed to register through the NNPTC, although you're welcome to stay and watch, of course. You just won't be eligible for CME credit if you didn't register. So anyways, you need to register on NNPTC and have to watch live and in full, and you're going to get an evaluation by May 9th. And so please complete that evaluation and check your spam notification or add nnptc@training.org to your safe senders. And CME processing, so you're going to be getting a evaluation, and then after you do the evaluation, you're going to be getting a notification to claim your CME certificate from the University of Nevada. And so, by the way, everybody who has registered for this webinar is going to be getting a copy of the slides and the recording. That's probably the most common question we get asked. So again, you'll get your evaluation, you're going to get all your post-webinar materials, and then your CME notification in 4 to 6 weeks. So by the way, you will not be able to speak during the webinar. The chat is going to be turned off, but the Q&A is turned on. I'm going to be curating all the questions. Please send us your questions. We know this is a very complicated topic, and we are getting into some of the nitty-gritty sort of herpes 2.0 today, but I know that you have questions and we want to be able to answer those at the end. And so you will see in the Q&A icon down at the bottom in the bar on your Zoom window. So please go ahead up to the last 2 minutes of the webinar, you can submit your questions. So, but there's no reason to hold them to the end. And then if you have questions about anything that I've just presented here, please email Elizabeth Olson, who's our program manager, and you'll see her email, elizabeth.olson@ucsf.edu. So without further ado, I wanted to introduce our expert speakers. The first person I'm going to introduce is Dr. Christine Johnston. She's an ID trained physician, adult ID, who performs many clinical studies of HSV. She was a subject matter expert and a co-author for the 2021 CDC STI treatment guidelines. And as I mentioned earlier, is the medical director of our sister training center at the University of Washington, which is part of the national network. And she's also an associate professor at the University of Washington. She is joined by the fabulous Terry Warren, and this is actually my first opportunity to do a webinar with Terry, and I'm very excited. She is a nurse practitioner who also holds a master's in counseling, and actually up until the recent past was operating a private STI clinic in Portland for years called the Westover Clinic, and now she's the head of the Westover Research Group because she's done many studies either as a principal or sub-investigator on studies primarily of genital herpes. And she also now has a telehealth practice where she helps patients obtain the herpes Western blot, and also does a lot of counseling based on couples who are concerned about HSV1 or 2, or just folks that are concerned about transmitting to future partners. And her current research is actually focused on comparing the routine IgG test that we have out in practice to the herpes Western blot. And so without further ado, I'm going to say our learning objectives are really to discuss the limitations of the currently available serologic testing and how to optimize testing using a patient-centered approach, and to understand the current landscape of HSV therapeutics as well as vaccines and what might be on the horizon. And to state 5 key messages that should be included when you're counseling someone with a new or existing diagnosis of genital herpes. And there's much more. This is actually sort of a selfish opportunity for me. I put in lots of questions that I get asked that I find confusing, and to have Terry and Christine sort of share their wisdom with us. So our IT folks at UCSF are going to actually help launch this poll. Terry had quite a few true and false questions for us to answer. So while he's doing that, I'm going to read some of these questions for you, and I want you to think about how to answer them. So question number 1, true or false? Oh, and it's covering up, sorry, the poll is covering up the slide. Can you see it, anybody?
I can see it.
Okay, I can't see the question, so I'm going to move this over here. So Ben, can I move this poll so that I can actually see the?
Yeah, move it wherever you'd like.
Okay, great. About 90% of the US population has HSV1. Is that true or false? All right, can I move on to question 2, Ben?
Yeah, we should show the results one at a time here.
Okay, great. Let's show the results of this poll. Okay, 66% say true, 34% say false. So Terry, make a note of this, okay? Next question, 30% of women in their 30s in the US have HSV. I can't read that. Is that 2? Yes, HSV2. All right, about 80% said yes, that's true. Question 3, men are more often infected than women. Let's see the results of our poll. Okay, most people say false there. Teens, so adolescents, are getting HSV2 more often than they did, let's say, in prior decades. Is that true or false? All right, 70% say that's true. Okay, and more people are infected with HPV than HSV2. True or false? Let's see what most people said here. Most people say true, that more people are infected with HPV than HSV2. And then IgM tests. So IgM antibodies, appear usually early in an infection, can tell the difference between, and new from an old HSV infection. Can you use an IgM test? Okay, false. And early use of suppressive therapy can delay seroconversion. So let's say you're exposed to HSV1 or 2 and you take early suppressive therapy, will it delay your seroconversion? True or false? Meaning the time when you have detectable herpes antibodies in the blood. Let's see what folks say. Most people say true, 60-40 though. All right. Terry, can you go over just a couple of these answers, and not in major depth, because we'll be talking about more of this later.
I'd be happy to. So the first one, 90% of the US population has one. That's false. Now we're at only about 47% of the population has HSV1, and that number has been consistently dropping. Number 2 is true. About 30% of women in their 30s have HSV2. Number 3 is false. Women are almost twice as likely to be infected with HSV2 than men. And the next one is also false. Adolescents are not getting HSV2 more often than before. They're actually getting it less often. The next one is kind of a trick question, because here we're comparing incidence and prevalence. So more people will get HPV, but most will clear. HSV2 is basically for the lifetime. So here we're talking about incidence versus prevalence. The next one, IgMs cannot sort out new from old herpes infection, and early use of suppressive therapy can delay seroconversion. I've had someone go 18 months who was treated early on with suppressive therapy, never did seroconvert, but had a positive swab test. So that is true.
Fantastic. That is a great way to lead us off. So I just wanted to show some pictures from Terry's practice. Terry, will you guide us through these as I scroll through them? Because, you know, I think we think of the typical presentation of herpes, and then I just think that there's such a diversity in the way that it can present. So I'm going to actually scroll through some of these pictures, which are from some folks in your own practice.
Well, they're either from my practice or other people's practice. Right. But yes, I'd be happy to. So I think one of the confusions is that people who get outbreaks on their buttocks have buttocks herpes, but really it's all genital herpes. When you think about the innervation of the sacral ganglia, we commonly see people with outbreaks on their buttocks. If this person has recurrent disease, we could back away from them a bit and possibly see scarring on the buttocks. We often get the question, if I have my outbreaks only on my butt, do I shed genitally? And the answer is yes. Next slide. So this is a subtle presentation. This is not from my practice, but this is a slide that shows how subtle HSV2 can be. This was actually detected by culture, not even PCR. And this was in a labial fold. And if this person had not sort of said, I'm tender right here, and folded back the labia here, we might never have seen this. So I think a thorough exam looking for subtle changes is really important. This woman might say, well, I cut myself shaving, or something, scratched myself with my fingernail, but this indeed cultured out HSV2. Next slide. So this is thigh herpes. So there is no such thing really as thigh herpes, but this person might say, you know, I don't have thigh sex. I don't even know what that is, but I don't know how I could have acquired this. But again, think about the innervation of the sacral ganglia. Often if we see lesions on the thigh, they're on a red base with grouped vesicles. And people get really worried when they have little ditzels on their thigh that this could be a herpes outbreak. But I think most people get little ditzels on their thigh from time to time, and it looks very different than this. I had a patient just this morning tell me, I have 5 little dots on my thigh, but they're really spread out. Is that herpes? And the answer is probably not. Next slide. So this is herpes in the urethra, and this patient is probably in quite a bit of pain when he pees, because this is an open ulcer in the urethra. And unless you had kind of looked inside, you would never have seen this. But someone that presents with dysuria should also be, you know, you could just take a quick peek, why not, and see that this is a lesion that's very obvious. I do think that men who have concerns about a sexual encounter will often look inside their urethra, and where they haven't looked before, they might think, oh my God, what's that? But the herpes lesion is pretty different than what people normally see inside their urethra. Okay.
Thank you, Terry. I appreciate that. Let me move on to our first question, which is actually for you. How well, one thing we hear from patients a lot is like, well, like if I have herpes, a condom, like for example, a male, an external condom or male condom only covers the penis. Is it even worth it to put a condom on? So how well do condoms actually prevent transmission during vaginal or anal sex, for that matter?
So we have some good data out of that, both from Anna Wald, and then there's a Scandinavian study looking at this. The study about male to female transmission found that when used very consistently, condoms reduce transmission from men to women by 96%. And I think that if we're talking about anal sex, that's probably similar, although we don't have that study. So that's very efficacious, and I think really good news for some people to hear. And then the transmission rate from women to men, male condoms aren't as effective there. They reduce transmission by about 65%, probably because vaginal secretions kind of cover a lot of territory sometimes. And women who have a lesion on the labia or viral shedding from the labia might come in contact with the base of a penis. So it's probably not quite as good. We unfortunately don't have great data on same-sex couples and how well condoms work, but at least we have this. The unanswered question would be, how about female condoms? Would they add something, especially to female to male transmission? And when people ask me about this question, I say, yeah, maybe, and I think it's worth a try. So unfortunately, we don't have data about that either. And then we don't have data about anal sex either, but I think that the condom reduction from men to women using condoms consistently is probably a reasonable marker. But anyway, condoms, especially from men to women, very effective because most virus is shed from men from the shaft of the penis. Yeah. So I think these are certainly helpful.
So Christine, do you in general, like for folks having some sort of penetrative sex, whether it's anal or vaginal sex with someone with a penis, do you generally encourage barrier use?
Yes, I think it's an essential part of our toolbox that we have to prevent HSV transmission, as well as, of course, other STIs. So I do encourage people to use condoms for prevention of transmission.
Yeah, and I just think this is because these studies looked at the per act transmission and the risk reduction, which are really, really well done studies. So I just think it's better than many of us thought it was. Is the point. And so Christine, since I just ended with you, I'm gonna lead off with you now. Can you just talk briefly about the HSV vaccines that are currently in clinical trials? And I know we don't have anything yet ready for prime time, but if you could just share a couple that may have some promise and what's going on.
Yes, definitely. So of course, for the prevention of herpes, a vaccine is really our holy grail, and so much work has gone into trying to create a vaccine. We're a little frustrated that we aren't there, but we're still working away at it as a field. I did want to point out in this table, you see prophylactic and therapeutic vaccines. One approach to herpes that's very interesting is we are looking for prophylactic vaccines, which are vaccines to prevent people from acquiring herpes. But we're also looking at therapeutic vaccines, and these would be vaccines given to people who already have genital herpes or already have HSV2 to try to both decrease their own risk of recurrence and also potentially to decrease the risk of transmission. So you can see here on this chart, many vaccines are looking both at prophylactic and therapeutic interventions. Another thing you'll notice about this table is the phase. All of the vaccine candidates except one are in the preclinical phase. That means that we still haven't put them in people. We're still very early in development. That said, there are some really interesting candidates out there. Delta GD2 candidate is actually has the glycoprotein D deleted. And this is interesting because glycoprotein D has been the basis of many of our prior vaccines that we've tried to use. A couple of other live attenuated candidates are deleted in some of the key replication proteins. And then we have a couple of very interesting mRNA candidates. You see the mRNA trivalent glycoprotein that's looking at 3 glycoproteins, and in the mRNA platform. And of course, we are all aware of mRNA vaccines now from COVID. It's going to be really exciting to see if we make any progress in our vaccinology using mRNA technology for HSV. In addition, Moderna has announced an mRNA platform. We don't know what the antigens are in that, but that will be interesting as well. And then in the only phase 1 study that is currently ongoing, we do have a recombinant protein adjuvanted vaccine that is currently being studied in the early stage, with plans to go into later stages, hopefully. So that's kind of the landscape. I didn't mention the product from Blue Willow. This is interesting just because it's a different delivery mechanism using intranasal delivery. So a lot of excitement out there. It's still very early in many of the phases, but we have a lot of hope that this field will advance.
Yeah, and I think, sorry, I just stopped my own video. I think one of the things we had, seen some like failures maybe 4 or 5 years ago, and I worried, like, are people going to give up? But I think it's, it's heartening to see that people are still plugging away at it. Terry, do you have anything to add?
No, I also am very excited about all that's going on. At last, we have some movement.
Yeah, and then my understanding is the GSK study is actually enrolling folks for this phase 1. Is that correct, Christine?
Yes, they are on clinicaltrials.gov. It said that they started rolling on March 7th, 2022. So yes.
Great. Let me advance here. So now we're going to talk about some diagnostic dilemmas and pitfalls. And I think this is probably the meatiest part of this webinar. And this is one of Terry's cases. So I'm going to have Terry lead us off.
Okay, so case study. 30-year-old man comes to your office stating that he ordered STI testing through an online provider, which I will add is very common. Most times these patients are sent to a large lab. They get a lab requisition, they take it to the lab, they have their blood drawn, and they get their results online. So an online provider, it comes back positive for HSV2 by type specific serology with an index value of 1.86, which is considered a low positive. He had his test drawn at LabCorp, and the supplemental test was also positive. What do you do next? So we're going to talk about this in the next few slides. So Christine, this is yours. Do you want to talk about this, or do you want me to?
Sure, I can talk about it. This is just thinking about the 2021 STI treatment guidelines, which came out in July, and some of the change, highlighting some of the changes in diagnostics for genital herpes. Now, if you have a lesion, if you're seeing a person who actually has a lesion to swab, please always obtain a swab from that lesion for a virologic diagnosis. This can tell us if the genital herpes is due to HSV1 or HSV2, which, as we'll talk about later, can have some counseling implications. Right now, the guidelines recommend type-specific HSV PCR as the preferred diagnostic test over culture. Type-specific HSV PCR is more sensitive than culture, but sometimes culture may still be required in cases of working up acyclovir-resistant herpes, which is quite rare. Now, this patient in the case study was screened for HSV infection for genital herpes, And that is often what happens if people are presenting in the absence of a lesion. If they're just wondering if they've been infected with herpes. We do that using antibodies, looking for type-specific antibodies to HSV1 or HSV2. But I think it's important to differentiate between diagnostic testing and screening. HSV type-specific serologic testing would be diagnostic if someone is coming with a history of potentially having herpes symptoms or being told they had herpes in the past, versus screening, in which people who may have never had a diagnosis or any symptoms would just be looking for infection. The other important change in the guidelines, or reiteration in the guidelines, is to really do confirmatory testing, especially in cases of a low index value, which we'll talk more about in a minute. The available confirmatory testing is with a BioKit test or a Western blot. And there are several real complexities of testing here that we'll get into further. Next slide. So I just wanted to point out in the guidelines, those people who you should consider testing for diagnosis of HSV, people who've had, who you may want to be, those would be people who have recurrent or atypical genital symptoms with a negative PCR or culture result. Those with a clinical diagnosis of genital herpes who have not had lab confirmation, or people who have a partner with genital herpes, so they've had known exposure. Among people who are at higher risk for infection, people, you may want to consider it for people who are presenting for an STI evaluation, people who are sexually active. We know that the prevalence goes up with the number of lifetime sexual partners, so and becomes higher with 10 or more lifetime sexual partners, and also in persons with HIV infection. Even for all people who you're seeing for a sexual health evaluation, you may consider screening for symptoms of genital herpes, as people may not necessarily be in tune to these, bring these up and see if by asking about symptoms, if you actually identify that they may have recurrent or atypical genital herpes type symptoms. I do like to point out that screening is not really recommended among asymptomatic people, according to U.S. Preventive Services Task Force. It's actually given a grade D, and that has implications for insurance coverage. And I think that is why when we were thinking about the treatment guidelines, we really wanted to try to focus on making a diagnosis for patients who may have had symptoms. Now, we do know that a lot of genital herpes is unrecognized. People may be asymptomatic. And so, it really is a difficult situation. And part of the reason why it's not recommended to test people more widely is because some of the pitfalls of the testing, and which we can maybe talk about next. Terry, do you want to add anything here?
Yeah, I would say just add, I think this is great. I think I would just add that though the U.S. Preventive Task Force doesn't recommend screening among asymptomatic people, a lot of people order their own testing, or clinicians who are not aware of the pitfalls order testing. It's a real bind, don't you think, Christine? I mean, people, as you said, a lot of people, 80% of people or more with herpes are asymptomatic. So we're caught in this bind. And I think, don't you think, Christine, if the test was better, we could use it more?
I absolutely wish we had a better tool to test, because I do think from a patient perspective, knowing your status, if you're sexually active, if you're entering a new relationship, that can be really powerful information to have. And so I think we really are stuck right now because of the testing issues that we'll talk about next, but we don't really have the tools to do more widespread screening.
I think that we we have Western blot confirmation. It's expensive and it's not easy to get. We have it, but for the average Joe, I think it's a challenge.
Yeah, and so I will say, just to dovetail on that before we get into pitfalls, is that I think many of those of us who practice in sexual health, when someone just comes in and says, test me for everything, that everything, and they don't have any symptoms, that everything doesn't often include a herpes serology.
And I think about that people will often say when they're diagnosed somehow, I thought I'd been screened for everything. You put a speculum in a woman's vagina and she thinks she's getting tested for a lot more than she might be getting tested for in particular.
That is such a great point.
And I think, just if I can add very quickly, for providers, I think that is important to point out to your patients that if HSV is not included in your screening, letting them know that and making sure that that's explicit, and then maybe having the conversation about if it should be included, because there can be cost implications too for patients. We have other patients who are charged from their insurance because it's not covered, and are actually upset that they're tested, or they're not aware that they're tested, and they have these results that they don't know what to do with. So I think just being explicit about what you're testing is really important.
Yeah. And Terry, I know that you have extensive experience working with, all of the patients that you've seen who've been tested at a commercial laboratory and maybe have had a confirmatory test at that commercial laboratory as well. So I wanted you to go over some of the diagnostic issues that you've encountered with these tests from different commercial labs.
I'd be happy to. So let's start with IgM testing. That was one of the questions. And we know that IgM, in my experience, and I've kind of kept track of this, has about an 80% or 85% false positive rate. So this is not an easy thing, because some clinicians still believe that an IgM is positive because people have new infection. So we're not just telling people you have new herpes, you're telling them that somebody just gave them new herpes. And emotionally, if someone believes that they're in a monogamous relationship, then they say, well, wait a minute, wait, this is my marriage, and they might get a test because they had some kind of ditzel on the labia, and all of a sudden they're told that they have new herpes and they're questioning their partner. So I think we need to just never, ever, ever do this. And Mayo Clinic stopped offering it in 2019. Quest and LabCorp have committed to us to stop it within 2022, stop offering it. But they've said that clinicians are kind of in an uproar about it. It's like, well, they just don't understand, I guess. And IgMs can be positive with old infections as well from time to time. So the Quest test, there's two big national labs that we've kind of focused on. The first is Quest, and they just published a study came out of Quest that showed if the index values on their routine test, if the index value falls between 1.1 and 3.0, 57% of those are false positives. I think that number is just stunning. Think of all the people who've been told that they have herpes when they don't. They do have a confirmatory test, but they don't routinely do it. And I don't think clinicians know to order it. So it's kind of a bad thing in my opinion. Now that they know this, are they going to go back to everybody who tested between 1.1 and 3.0 and say, oh, let's do the confirmatory test, or you should get a Western blot, you might not have herpes? I think this is shameful. We also have people who've tested positive on their inhibition assay and negative on the Western blot. So I probably have, 15 or 20 people for whom that has happened. And I'm keeping track of that data as well. We don't have data on the LabCorp IgG specifically, but in my experience, it's no better than Quest. But the problem with LabCorp is that they now, with their heart in the right place, are doing confirmatory biokits on people who have an index value of 1.1 to 5. So that test, the biokit, is a good little in-office point of care test. But I'm going to show you a slide that shows you that those results are not easy to read. What I think is going on with LabCorp is that they are way over reading this test. I have presented a paper that we're going to show you a slide about, and I continue to gather patients. I'm up to about 75 patients who have positive IgGs from LabCorp, positive biokits who are negative by Western blot. And in my experience, ClinPath labs and BioReference are equally poor. Next slide. So Christine, this is your slide, isn't it? Oh, this is, I know.
It is, but it's from your clinic, Terry. Basically, Terry has been doing an incredible job really tracking all of these patients and identifying some of the issues with the serologic testing. So this is a retrospective study amongst 864 patients who had HSV EIA and then had a Western blot. And really the issues that came up were both false negatives for HSV1 and false positives for HSV2, with, again, about a 57% specificity for HSV2. And this is just really showing that it's dependent upon both the index value and the HSV1 serostatus. So you can see here in this chart, the index value of 1.1 to 2.9 had only 39.8% specificity. I mean, that is worse than a coin toss. So that is really poor specificity. It did go up when you had an EIA of 3 or greater to 78.6%. So it's better, but that's still not a great test. And I think it's important to realize that even though our guidance right now, it says confirm if it's an index value under 3.0, even over 3.0, we are seeing some false positives. There are some issues with the study. People are self-selecting to go on to contact Terry's clinic and get the Western blot. Maybe some selection bias, but it is a validation in a real world setting, and it's consistent with previously published studies. So I think it really just demonstrates, another set of data that the tests that we have available really are not adequate. Next slide. And back to Terry.
Oh, sorry.
So this is just the lack of sensitivity of the HSV1 test. So it misses 30% of infections. So if you're missing a third of people who have HSV1, that's not great. So when I order Western blots look for both type 1 and type 2. A lot of people are finding out that they have HSV1 when their IgG test has been negative. And then the issue is, okay, where is it on my body? And we can't tell them, because a Western blot only tells you if you're infected or not. It doesn't tell you if you have it orally or genitally. And that brings me to another point. I think it's really important that we as clinicians totally get rid of the word exposed. You've been exposed to herpes. That's just BS. That's not what it is. If you have a true positive antibody test, you're both infected and potentially infectious to others. So we need to never use that word exposed. It's like a pregnancy test. It's not positive because you got exposed to sperm. Well, yes, you did, but you're also pregnant. So I think it's important that we use the right language here. And the HSV1 thing is tough because Christine, I think it's true that the majority of brand new cases of HSV, genital herpes now in the US, is HSV1, not HSV2, though the majority of recurrences are HSV2. So these positive ones are starting to stir up a lot of conversation. Would you agree, Christine?
Yes, absolutely.
And then can I just add that I think sometimes patients get diagnosed with genital HSV1 on a PCR, which we know is very sensitive and specific. Then they want to say, oh, I want to make sure that they get an antibody test for HSV1 and it's negative, right? And so I think we need to have a conversation as clinicians with people to say that test is really poor. The HSV1 PCR is the one that you should believe, because people want some sort of confirmation with a blood test that they have it, and then they're using a much less sensitive test.
And they often want that confirmation because they're not having recurrences, because genital HSV1 doesn't recur much.
Exactly.
And so they're thinking, wow, that swab must be wrong. And then they get a test that says they're negative, and then there's just all this confusion.
I know, exactly.
So next slide.
Yep.
Go ahead, Christine.
Yeah, this is getting into, both of you guys are going to need to weigh in on this, but the CDC you mentioned recommends the use of two-step testing to confirm positive serology with the Western blot or the BioKit. But Terry, you had just mentioned that there might be some overreading of the BioKit, and you have some nice pictures here. So I'm going to advance the slides to show those.
So this is from Rhoda Ashley Morrow's work. She's a wonderful clinician at the University of Washington. So this, retired now, but this is the top one is negative BioKit. The second one you can see, so the deal is if there's a pink dot, it's positive. Well, we did this in our clinic for probably 3 or 4 years. And I remember us so clearly standing in the lab with 5 people around this little thing saying, do you see a pink dot? The problem is this pale thing here is probably most often not positive. When it's really positive, you can see that the pink dot, boom, it comes right up. It's profound, but this is where the confusion is coming in. And we spent quite a bit of time talking with the LabCorp people about this problem. They're definitely aware that they are over reading this, but there's no sort of test insert that says there's an indeterminate result. So we're kind of stymied there. And this slide just looks at this paper that I did. I kept track of these people with indeterminate Western blots. And we don't need to go into this, all of this, but it's, yeah. So this is about the University of Washington Western blot. This is the gold standard for most of our clinical trials. People have to have a positive Western blot to enter. And anybody can do this for their patients. So you call this phone number, they will send the patient or the provider a kit. It's just got a serum separator tube and a little transport tube and a lab instructions, labeling for the outside of the package, and the address to ship back to UW. So if you have a situation where somebody wants a Western blot, but you don't have a kit, that's okay. You can draw 1 serum separator tube, spin it down, and preferably pour it off into a little transport tube. They need a lab requisition, but you can find those online, or I have them. And that needs to be filled out by the clinician. And so if somebody wants it immediately or they live out of the country, I have lots of patients who don't live in the US. And the big problem is where to get your blood drawn. And for right now, I have 2 lab chains that will draw people, process their blood. Any lab tests now, there aren't any in California, but there are ArcPoint labs in California. And I have particularly one in West LA that I use all the time. They're really good at it. They know exactly what they're doing. Unfortunately, these 2 big labs who create the problem refuse to draw blood for these people or ship it to the University of Washington. They won't even draw it if they have a kit. So there's, in my mind, that kind of sucks because hello, you're kind of creating the problem with your bad test, but you won't help sort it out. But these places will draw blood. They charge people $40 to $50. People need to get a prepaid shipping label, and they can do that online, or they can do it at a FedEx or UPS store, and then ship it off. So the next slide, I think, talks a little bit more. So patients purchase this label online. UW will not bill insurance companies for out-of-state patients, so it's a cash deal. The cost of the test is around $255. Then the patient has to pay a blood draw fee at overnight shipping. The results are either positive, negative, or indeterminate, and we're seeing an increase in indeterminates. We don't know why, but it's really frustrating. If the result is indeterminate, they're told to redraw in 3 months, and if indeterminate again, consider themselves negative. If they haven't had sex in a year, the lab told me that they should consider the indeterminate a negative. People could have an indeterminate because they're in the process of seroconversion. I will say, and I don't draw them, I don't order this test unless it's been 12 weeks since they've had a concerning sexual encounter. And then the sensitivity is 99% for type 2, 96% for type 1. But people, go ahead.
So it's and just the point is it's the only game in town in terms of we're not necessarily trying to sell the University of Washington product. It's really the only lab that's doing it in the United States at this time.
Absolutely. And that's kind of frustrating too.
Yeah. Moving on to genital HSV1 shedding, Christine, because I think this is really exciting data that is special for our audience because it hasn't yet been published, but I want you to talk a little bit about HSV1 shedding compared to HSV2 shedding in terms of frequency.
Yeah, so this has been referenced already a little bit, and I do see some questions in the Q&A about HSV1, genital HSV1 infection. It is an area that's really growing. We're seeing what's been termed this epidemiologic transition of HSV1 infection, where HSV1 is the primary cause of first episode genital herpes in several settings. For instance, in Melbourne, it increased from 45 to 54% of first episode genital herpes cases. Similarly in public health in Seattle, King County, over half of the cases now of first episode genital HSV1 are due to, first episode genital herpes are due to HSV1. And this modeling study suggested that over time, an increasing proportion of HSV1 infections will be acquired generally. And I think these are kind of complicated figures on the left, but if you look at figure C, you're seeing in 50-year-olds, the proportion of cases that are orally acquired, you're still seeing over time, over the next 100 years, that about 90% of them in that age group are going to be orally acquired. But in the younger age populations, especially the 15 to 29-year-olds, we're seeing that a decreasing proportion of cases are orally acquired, and therefore an increasing proportion are generally acquired, going up to potentially 25% if the modeling holds. So, and this is partly because, as Terry mentioned at the outset, we're seeing a decline in HSV1 seroprevalence in the country. And this means that people who are adolescents and young adults are sometimes now being exposed to HSV1 for the first time when they initiate sexual activity. Next slide. So this is a study that we did here, enrolling patients with first episode genital herpes and following them over a year-long period. And then we did ask them to do shedding sessions where they collected 30 days of swabs, both oral and genital, at 2 to 3 months post-infection, and then again at 11 months after infection. And what you're seeing here is the wide variety of shedding rates. Each bar here represents one person in the first session in blue and the second session in orange. And you can see that in the first session, the shedding rates range from 80% of days with shedding detected to many people who didn't have any shedding detected, or who had less than 10%. And then what you can hopefully see just visually, overall, there's even less shedding in the second period. But there are some people, such as participant 10 here and participant 19, who actually did have increased shedding in the second period, but it was decreased, overall on a population level, it was declining. Next slide.
It's just so the numbers along the bottom represent the participants' number.
Yes,
Yeah.
that's just the participant number. Yep.
Got it.
So people often do wonder, how does genital HSV2 shedding compare to genital HSV1? And this is mainly due to concerns about transmission. And people wonder, is HSV1 infection more or less transmissible than HSV2? And we really didn't have the data about how often HSV1 is shed generally using the more sensitive PCR test. So this just kind of shows the shedding rates of HSV2 in orange over time, and then the HSV1 shedding rates in session 1 in black and session 2 in gray. And what you can see here with first episode genital herpes, the shedding rate on a population level is over 30% for HSV2. For HSV1, it's 15% in that first 2 to 3 months post-infection. It goes down to about 7% by 1 year out. So really, we're seeing a rapid, the virus is being controlled. It's not being shed even at a year very frequently. Compare that to people who are symptomatic with HSV2, even at less than 10 or even more than 10 years out, their shedding rate is higher, closer to 20%. So we clearly already knew clinically that genital HSV1 recurs less than HSV2, and now we have some shedding data as well to suggest that it really is shed much less, and hopefully that means it's much less transmissible. Next slide. Yeah, yes. And Terry, if you want to add anything there or any other questions.
No, it's just so great to be able to see it and to be able to talk to patients about it.
Yeah.
Oh, and I think one other thing from that slide,
please.
You looked at the asymptomatic people. They're still shedding 10% of days, which is why I think that people that have never had a symptom of herpes that are trying to reduce transmission would benefit from suppression.
Mm-hmm. And we'll talk a little bit about more about that in a later slide. just for the interest of time, Christine, we don't have that much time to spend on it. And I know you don't have a ton of news about any new therapeutics on the horizon here.
Yeah, this slide just shows maybe my frustration and the frustration in the field. This slide was made in 2015, and I actually have a very similar one from 2006. And we really just don't have any new therapeutics available. We've had the same things for about 25 years. So nothing new in terms of treatment at this point. There are several, things that are being studied. There's a novel approach looking at HSV cure using a gene editing approach, still in the preclinical phase. There are drugs that have a novel mechanism of action. Monoclonal antibodies are being studied, as well as helicase primase inhibitors, which again have a different mechanism of action from our currently available antivirals. But so far, none of these are ready for prime time. I will point out there is a study of pratilovir, which is a helicase primase inhibitor for people who have acyclovir-resistant herpes. So if you are coming across that in your clinical practice, please see if your patient may be able to participate in this trial.
Great. And so this question is really for both of you, because I know that you guys have both seen this clinical scenario, as have I. Sometimes people are taking suppression and they're still having outbreaks, coming through, and just wondering what adjunct therapies you use. And if you do bump up, valacyclovir, for example, for suppression, how much have you increased the dose for people? And so if you could both comment on that, that would be great. I'm going to advance the slide here.
So I think Christine and I both agree that the first thing to do is and I often send swabs home with people. I will send them from Portland all over the country to people so that they can gather their own swabs from outbreaks. And that helps them to know if these things that they're experiencing as breakthrough outbreaks really are herpes. And I will tell you that most of the time, with the PCRs that come back to me, they are not. So Christine, you want to talk about the next one?
Yeah, so I think the second question is the suppressive therapy dose adequate for your patient? Be aware that higher doses are recommended in people with HIV infection. And also that a higher dose of valacyclovir is recommended for people who are having 9 or more outbreaks per year. For most people, valacyclovir 500 milligrams daily is adequate, but actually even in the early clinical trials, 1 gram was required for people who had frequent recurrences. And then, I always ask, can the drug be pushed? If people are tolerating it, the drug actually is safe and tolerable. And I've gone up to 1 gram twice a day. But I think that, I have seen people coming to me on 2 or 3 grams twice a day. And I really think that there's very little benefit in going beyond 1 gram twice a day. You really run into toxicities. And I really start to ask if there's something else going on, if people are breaking through to that level. Terry, do you have anything to add on that?
No, I agree. Sometimes I try 500 BID just to keep the dose a little more even to see if that helps. But I think, going much higher, I don't see any benefit.
So Terry, these folks that you might be sending with swabs, and they're swabbing what they think is an outbreak, so some other skin condition that is not genital herpes, essentially, is what you're saying.
Right. I tell people not everything that happens in the genitals of people with herpes is herpes. So I encourage them to do that swabbing, and I have people doing daily home swabbing and sending me swabs. It's expensive, but it really helps people to understand this.
Yeah. How about adjunctive things like been asked many times about L-lysine and as well as a low arginine diet. Can you guys both comment on that?
I don't think it helps much, but some people think it does, and I don't see any downside.
Yeah, I think the theory behind it is in vitro HSV uses arginine to grow, and L-lysine antagonizes arginine. So it seems like it should be a really nice package and should be very effective. But we don't really have any evidence. The evidence that we have are really small studies, subjective endpoints. It's not at all, rigorous evidence. Similar, however, to Terry, I don't, if people want to try it, I don't have a problem with it. And some people do swear by it. They feel that it works. My main point is please don't spend a lot of money on things that aren't proven to work, because I think there are a lot of people who are taking advantage of people who are vulnerable with genital herpes, who are, really willing to try many things to avoid outbreaks.
And that's the point of your buyer beware slide, which is the next slide here. Many, many cures, natural remedies, herbal remedies being sold for HSV.
Yes, exactly.
Another question for both of you that we get asked a lot is about suppression for people with genital HSV1, given, you showed the dramatic decline in that second session of folks who were actually shedding. What do you guys say to people? And then what about for folks with HSV2 who don't have recurrent outbreaks? As we saw, about 10% of people who are asymptomatic are still shedding with HSV2.
I think that's that people who are asymptomatic shed on about 10% of days.
Yeah, days. Sorry. Yes. Sorry about that.
Yeah. So I think, I think this really requires a conversation with your patient, and it's kind of a shared decision-making model. For people with genital HSV1 who have recurrent outbreaks or frequent outbreaks, definitely offering suppressive therapy. We know that suppressive therapy stops outbreaks and improves the quality of life. But beyond that, I think it's a discussion about people, determining how concerned people are about transmission, and then letting them know that we really don't have the data for how effective this suppression is to prevent HSV1 transmission. Of course, it's going to suppress shedding as it does for HSV2, but because the shedding rate is so low, we don't really know the magnitude of that benefit. So is it worth to them taking a medicine every day for an unknown benefit, or is it something they would rather not do? And I think it depends how much distress the genital herpes diagnosis is causing them and how concerned they are for transmission to partners. Terry, what do you say?
I say that if they have, I think sometimes people take suppression who have genital HSV1 as a reassurance for themselves and for their partners that they are doing everything that they can to reduce the risk of transmission to a partner. But I also let them know they're probably not shedding very often, but I have some people who have more recurrences, and I think this drug is safe. It's only activated in the presence of viral enzyme, and there's no reason not to do it.
Yeah, and I think pretty similar points too for people who are asymptomatic with HSV2.
Yep. And just wanted to show this slide, which is kind of the seminal study looking at risk reduction to partners who, and then we talked about this before, that the people who entered the study had to be having multiple outbreaks per year, at least 4 outbreaks per year. So,
yep, with genital HSV2.
Yeah, that's right.
Yeah, and also just to point out that it's not 100% reduction, it's 48% reduction. So this is also not a perfect intervention. We wish we had a better one that was closer to 100%. But.
Yeah, so we don't have actually any data slides for this, but when people ask for people who have HSV2 and when they ask about the risk of transmission to folks that are performing oral sex on them, what is the sort of general sort of spiel that you give?
I tell people that HSV2 doesn't like the mouth very well, and that it's not common to be infected orally. It certainly could happen. I've seen patients who have HSV2 orally. Often they have it in both locations, so they have intercourse with and give oral sex to the same person. And I think we don't have a great answer. We don't swab cold sores, so we don't know how many of them are positive for HSV2, but I think that it's uncommon. What do you think, Christine?
Yeah, I agree. I think it's very uncommon to see symptomatic or even shedding of HSV2 in the oral tract. The symptomatic cases are on the level of case reports in the literature. So I generally try to reassure people that this is a less likely outcome of transmitting to the oral sex partners.
That's helpful. Just some parting words here, some counseling messages. This is Terry's slide. Terry.
Yeah, so I think having a master's degree in counseling have helped me enormously in this field because patients are generally pretty unhappy and freaked out. The next slide. So I think there's some basic counseling messages that you can give to people that don't take a long time, that are simple, but they need to come from your heart, I think. The main message is you're still the same person you were before. Lots of people find out that they have herpes that have been infected for years and they're not, you know, they weren't any different before. They just know about it now. So you can still have a children and family if that's what you want. You can still have sex, but you really need to disclose your HSV status. A hot topic right now is, do you have to disclose that you have genital HSV1? So that's a tricky one.
Next one.
You can transmit virus between outbreaks. I think that's the hardest thing for people to hear. There's not a day that you can say to your partner, I know today with 100% certainty that I won't infect you. There are safe and effective treatments. Please give yourself time to feel better. You're not going to be like next week, fine. Maybe not next month. But in 6 months, I think our data shows that you're going to feel a lot better. You're never going to be happy about this, but time does make it better. I think you should tell people they can come back and talk to you, or if you don't want to, you don't feel like this is your area of expertise, have some references available, therapy references or support groups or websites, and have that available that you can give to them. It doesn't take a long time to do these messages, but I can't tell you how many people have told me, you know, I got an email, you're positive for HSV2 with a 1.1 index value. You'll have this for the rest of your life. It's like, wait, we can't just do that. That's like dropping a bomb on somebody. I think we need to do some minimal counseling around this topic for people.
That, and I think many people have received the diagnosis or just been told about the positive test result, and then there's a zero follow-up. And I think that's really doing a disservice to people when it's something like HSV. Just some more resources. I just want to plug the University of Washington and NPTC's National STD curriculum. There is a herpes module, there's an HPV module, and gonorrhea and chlamydia, all the big ones are here. If you are an STI junkie and you want some free CME or nursing credits or other CE contact hours, there's also pharmacology credit, so please check it out. And again, if you have a difficult question, please send it to us at the stdccn.org. This is the website for Terry's practice if you want to refer someone for a telehealth visit or a Western blot testing, and Terry and Christine's emails. And once again, of course, we are going to be providing all of these slides to you for the future, but we have a ton of questions, so I'm actually just going to launch right into that. And Terry, just about your practice, do you accept insurance, and what is your sort of standard sort of entry fee for a counseling session?
I don't accept insurance. I don't bill insurance. And the Western blot through me because I get somewhat of a discount through UW. So the cost through me of the test and the consult with me is $325.
Got it. Thank you. Mm-hmm. And I think we answered this question about, I see a fair share of HSV1 in the genitals and how often is it showing up below the belt? I think we are all in agreement that it's a increasing cause of genital herpes and the recurrences are much less likely. And I think you said 7% of people really are shedding in the 11th month, right after they are first infected. And many of those are not even having a second outbreak.
And by the end of 2 years, her data shows very little shedding, right, Christine?
Yep. Yeah, that's right. Right. But it is 7% of days, not which people
7% of days. Okay.
7% of days. Yeah.
Got it. So would you recommend inclusion of HSV2 only, or would you actually do HSV1 and 2 serology testing if you were going to be doing, in a college health setting for an STI panel, if, the indication exists to do HSV testing?
Yeah, that's a hard one.
I know it is, right? The clinic where I happen to be, we only look at HSV2 serology. We actually don't order HSV1 serology, but many settings, private settings, order both. So I'm just curious if you guys have an opinion, and you don't have to answer if you don't know the answer.
No, I think it's a difficult question. I mean, I think the lack of sensitivity, knowing that you're going to be getting many false positives with HSV1 combined with false negatives combined with not being able to say if it's oral or genital. It's just can be very confusing for people. And again, I think that this is where I come down to, are you doing the screening or a diagnosis? So I may definitely order a diagnostic test in someone who has been exposed to genital HSV1 and is curious if they're infected now, after, 12 weeks after an exposure, versus just blanket screening everyone.
Right. Nobody wants to do that, it doesn't sound like. So this is a great question. What's a ditzel? I can answer that. It's just like a little thing that appears on your skin, like any random little red dot or lesion or ulcer, and it's just a ditzel.
Is that a Jewish word?
It's a splitz. Yeah, it's right. I think it's Yiddish probably or something, but yes, it's splitz. If someone has an oral HSV1, can you actually transfer it to your genitals if you were to, for example, put your hand in your mouth and touch your own, vagina or penis?
I would say that once you have a well-established infection with either type, and I would say well-established infection is like 3 months out, that it's extremely unlikely that you would transfer it to a new place. In all 38 years of practice, I have seen it happen once. Somebody had reported a cold sore history that seemed solid and they have genital HSV1. Now, to be honest, I don't think we really know, because if you got it in a new place, it would probably be asymptomatic, but I think it's unlikely. What do you think, Christine?
Yeah, I agree. I think you're absolutely right. I think we're trying to learn more about if people can, if they already have oral HSV1, can they be infected by someone else in the genital tract with a different strain of HSV1? And I think that some of the sequencing that we can do now can help elucidate that question. But I think that most likely once people have protected against that same type elsewhere on the body. So if you already have oral HSV1, I think you're unlikely to get genital HSV1 with a different strain.
And I think it's also important that people know that if you have HSV2, the odds of getting HSV1 are just infinitesimal. But the reverse is not true.
Yeah, that's a great point. And that's someone is asking that, is there cross protection if you have one type of HSV against the other type? And so I think you mentioned that if you have HSV2, the likelihood that you're going to be getting HSV1 on top of that genitally, for example, is very low, but the converse may not be true. And how often do you see people who have both types, for example?
Rarely.
Rarely.
Both types in the same place, rarely.
Okay.
Yeah, but unfortunately, HSV1 does not protect against HSV2 infection. We have many people who are co-infected with HSV1 and HSV2. People who have HSV1 pre-existing condition may be less likely to have a symptomatic HSV2 infection at the time of acquisition, but you're not protected from acquiring HSV2.
Yeah, and the second part of this question, I think you guys both answered how easy it is to auto-inoculate or self-inoculate other body sites. If you don't have a well-established infection, in theory, and you don't have antibodies, in theory you could, but I think both of your points is that once you have antibodies, you're not going to auto-inoculate a different site on your own body. Is that correct?
Yes.
Yes.
So another person asks about the bio kit. What type of specimen? Is it a finger stick? Is it a blood draw, Terry?
It can be a blood draw or a finger stick.
Okay, fantastic. Okay, if someone has a positive IgG for either one or two, what are the chances that they will never be symptomatic? Is it possible, I think this person's asking, is it possible they just never realized that they had an outbreak and and they happen to have the antibodies because they didn't realize? And I think I know the answer to this, but go ahead.
Well, it seems like first of all, you should confirm that it's really a true positive. I've had false positives up to 17 on an IgG test.
That's
17.
Insane. That is insane.
And lots of them between 4 and 5, lots of them. But I think that, isn't it correct that about 80% of people with HSV2 are asymptomatic, and or say they don't have symptoms, but actually many of them do. They just don't know that they're herpes symptoms. And then about 70% for HSV1.
Yeah, I agree with that. I mean, I think we often say, 80% of people with HSV2 are undiagnosed, and that doesn't necessarily mean they're asymptomatic. It means they don't know that they are having symptoms that are due to genital herpes. Once they're educated, often they can identify symptoms, and they're not necessarily a classic ulcer. They're more like that excoriation. I think that was a great picture that Terry showed of a very subtle manifestation of herpes that you just would never think of unless you knew what you were looking for.
Someone was asking, CDC's recommendation about testing for HSV antibodies in certain situations when someone's symptomatic or whatever. Are they meaning to test for HSV2 or both 1 and 2?
The guidelines are more focused on HSV2 antibody testing.
And a question for you, Christine, about how are you determining people who are shedding without, if they're not having clinical manifestations, how are you determining that they're shedding?
So that's actually with some of the clinical research that we do, enrolling patients in studies to collect genital specimens and oral specimens every day over a specific time period, and having them at the same time fill out diaries saying whether or not they're having symptoms. So it's really, it's not clinically that we've done that. It's all been based on clinical research.
Right. And that there wouldn't be a way for people to do that clinically, I think is you're put in their practice.
Yeah.
Oh, I think that there is a way. I think that if somebody wants to do daily home swabbing, you can do that. They can go home with swabs, collect them, bring them in a week later, keep them in their fridge. I mean, that can be done. It's expensive.
Yeah, I was just going to ask you, Terry, that would probably run people many hundreds of dollars, I'm guessing.
Well, it's about 125 per PCR through my resource.
Got it. And so someone asked, can you clarify shedding? Can you say after a new HSV2 infection, they're shedding the most during the first 2 to 3 months? And what's asking, is that showing people who were taking suppression or not suppression or not taking suppression?
So that specific slide was people who were not taking suppressive therapy. So this is shedding in the absence of any therapy. For HSV2, shedding is really, the shedding rates are looking at various times over the first year. For HSV1, we were able to say that most of the shedding is occurring during the first 3 months based on the study that we did.
Do you all have a preference for valacyclovir over acyclovir for suppression in terms, other than convenience of dosing?
No, if they want to do it twice a day, I don't know. We don't have as good a data, I don't think, on acyclovir as we do about valacyclovir. But the prices are pretty close. Although if money is a real issue, they can take 200s twice a day. And though the 200s are on things like the Walgreens $4 plan, so it'd be about $16 a month. But valacyclovir is getting pretty close.
That's great. And then Christine, no preference on your end either?
No, I think it all comes down to if patients want to take a 1 versus 2 times a day medicine, and then the cost to them.
Yeah. And then folks, when someone comes to you and they're having their first, first recognized outbreak and they're traumatized or whatever, what do you think about just starting general suppression for everybody? You know what I mean? And then saying, just take this for the next several months or a year, and then let's take you off and see how it goes, kind of thing. Someone was asking about that approach.
So that gets back to one of the points on the true and false. I think if you have a positive lab test, it's fine to go ahead and start suppression for a year or whatever, because people are so traumatized. Right. But you've got to have a lab test, because it really does. And University of Washington lab now with the Western blots is also saying that suppression can influence an antibody test. So we need to be careful about that.
Yeah. And another question was asking about the HSV1 shedding study, Christine. The graph that you showed was for genital shedding, but you mentioned oral shedding as well. But they were asking, when you were talking about HSV1 shedding, you were referring to the genital results, yes?
Yes, yeah. I didn't show the oral results, but regardless of when people were after their infection, whether it was 2 months or 11 months, the shedding was about 3.5% of days.
Do you all have longitudinal data on the percentage of patients with genital HSV1 who are a one and done and never have another outbreak?
We do. Isn't it? If you don't have another outbreak in the first year, there's an 88% chance you'll not have another. Is that right, Christine?
That sounds right. I don't have that specific number at my fingertips, but that sounds about right.
I think
So,
that's
yeah.
There are like 20 more questions that we're not going to get to, but because we're at time, but I just wanted to point out the last slide up here, just, we're going to have this whole recording, all the slides for you, but if you want your CME, please, you had to have registered and have been here live and watched it in full, and please complete your core survey by May 9th. I think we need to have a herpes 3.0, but we'll wait a time period so as not to burn you out. But this was just so fantastic, and I learned so much, and I know our audience did as well. So I just want to thank Terry, Christine. I really appreciate you both. Here's your contact information again for our audience. And thank you everybody for coming. We're going to be having another STI expert webinar in May, at the end of May, on genital dermatology, which is going to be really fun with a fantastic speaker, Ken Katz from Kaiser. So thank you both so much, guys.
welcome.
Thanks everyone for being here.